Hello and welcome to another Piper Pearl. Today's Pearl, we're going to look at abnormal uterine bleeding and premenstrual syndrome. Now these two connecting and synergistic conditions are unfortunately quite prevalent in most societies actually, and they'll often vary in their magnitude and their presentations, and it can be a very difficult consultation to have. Now, I'm not blind to the irony that I am in fact male and therefore will never suffer from abnormal uterine bleeding or PMS, which sometimes adds to the complexity of consultations surrounding these particular disorders, because you're going to get male clinicians and you're going to have male clinicians. And by virtue of being a female clinician doesn't in fact mean that you are now ordained, you must now deal with all these conditions because males couldn't possibly understand them. So part of the goal today is to discuss them frankly, honestly, based on research, science, and try to offer some advice of how to approach a patient and how to talk to a patient with abnormal uterine bleeds or suffering from PMS or PMDD, depending what the case may be, and hopefully build conversations around it, because it shouldn't be taboo. It is a natural process, and unfortunately lots of things can go wrong when you're dealing with the uterus, and manifestation of menstruations can have some pretty significant side effects and impacts on a patient's life. So moving straight into it, looking at the introduction of the numbers of people that are affected by it, up to 30% of women have abnormal uterine bleeds. Now, the incidence of primary complaints is in people coming in complaining of some sort of abnormal uterine bleed. Now, this can include pain, discomfort associated with menstruation, and also generally a complaint of heavy flow. The incidence of that primary complaint are very high. But of those numbers, around 50% of them are deemed normal through investigation. And this is where it gets quite difficult, because a clinician is telling a patient that what they have is normal. And it can be a very difficult thing to do, because normal is a relative term. Now we'll go into what the clinicians and the studies mean by normal as opposed to a heavy flow. But just keep in mind that if a person has come in complaining of abnormal uterine bleed, then it means it's abnormal to them. So it may not fit the box and the criterion, if you will, but it's still a concern for that patient. So doing a workup and a consultation, and yes, educating is important, but dismissal should never be the first point of call. When we look at PMS, it is said that around 90% of women are affected by PMS to some degree. 20% of those women, it actually affects their lives to some extent, and 3% is severe, classified as severe. So that's when you start moving into the diagnosis under the DSM-5. Now, when it says the terms affects the patient's life, that doesn't mean that they're feeling uncomfortable. They're having discomfort. They're maybe a little bit short at work, a little bit snappy at times when they'll be more controlled, a little bit dysregulated as far as emotions go. We're talking having physical impacts on their work life, on their social life, or on their home life. So PMS has got to the point that it is actually negatively affecting aspects of the person's life as opposed to the patient's comfort, because you could argue that all forms of PMS affects the patient's life. But we'll go through a few criteria of how they break down different levels of PMS and how the best support is provided. Now, for both these conditions, the possibility of pregnancy is a complication. Okay? It makes it much harder for both the conditions and a much different line of investigation for both of them. So it needs to be considered. The patient needs to be asked, not assumed that they could be pregnant. Just because they're coming in with menstrual problems doesn't automatically mean that they're sexually active or have sex with men. So we need to ask, and if there's a possibility, then it needs to be tested and considered. At no stage should we ever pretend that this is an easy consultation, a comfortable consultation for all people to go through, patient and clinicians included. In order to do it successfully, you really need to establish a rapport with the patient. If that rapport is not there, it's sometimes not your fault as a clinician. It's sometimes not the patient's fault. It's just not there. And like a psychologist, it is best that you refer that patient on to someone who is likely to have more rapport in order to get a good consultation and better management for that patient. Try not to take it personally, even though I know how difficult it can be. Sometimes the patient's comfort outweighs ours as a clinician's ability to do the job. So just weigh it up. Moving on from introduction, I think it's best if we have a look at a review of the menstrual cycle in order to understand what we're talking about. So we're going to review the ovarian and the menstrual cycle combined, just so we can have a better appreciation to what we're talking about when we move into our subjective data.
This is as easy as we can make it, and obviously there's a lot more that can be looked into from this, but this is generally the way that the ovarian and the menstrual cycles work together. All things start in the hypothalamus with the gonadotropic releasing hormone. It stimulates the release of follicle stimulating and luteinizing hormone. Follicle stimulating hormone is responsible for the production of follicles within the ovaries, which produces a viable ovum and releases estrogen. Easy done. From there, once we have a viable ovum, estrogen causes the luteinizing hormone to increase. And when you get that luteinizing surge, you get ovulation and corpus luteum production. With corpus luteum production, we finally have endocrine tissues that can increase the amount of progesterone that is produced. Then, in the absence of any feedback, like implantation, the corpus luteum will decrease. The follicles themselves size will decrease, and therefore the level of estrogen and progesterone will drop, causing the thinning and the falling out of the uterine lining, known as menstruation.
Revisit more detail on the female reproductive system, then you can go back and have a look at the anatomy physiology lesson. But moving on, let's talk about a few of the barriers that come into these consultations, and we'll start with the abnormal uterine bleed. So ignoring the potential gender difference and the fact that it's quite a taboo subject, and there are still cultures and environments that periods are not to be talked about, and menstruation is a private thing that's never to be discussed. So ignoring all that, it's also very difficult because of the nature of what is normal and what is defined as normal and what parameters have been set up to denote certain conditions. So when we talk about normality of menstruation, we talk about a length. Now, generally speaking, the mean length is 26 to 28 days of a period. So 28 days will constitute the entire menstrual cycle. However, it is still normal to have 21 days and up to 35 days between cycles. So between menses can be 21 to 35 and still be considered within that realm of normal. Now, that's not to say if anyone was to go 20, that it's definitely a massive pathological problem. Okay? It's just the parameters. The flow generally goes for about 3 to 5 days, but can extend from 2 to 7 days. Blood loss, now this is talking blood loss, is normally between 20 and 80 mils. So therefore anything over 80 mils is considered a heavy flow. Which brings us to the next problem, is how on earth do we educate our patients to measure their flow? Now, a lot of things have come out, and even on female websites called Flow comes out with recommendations of what is considered the best way to measure things. Now, they sound ridiculous, and we'll go through and we'll explain why. So obviously you can have a menstrual cup, and they recommend this being the best way to measure menstrual flow, assuming of course when you take it out you don't spill it, but it's there. That's the best way. Now tampons, generally speaking, the normal tampons hold 5 mils. The larger tampons hold up to 10 mils. This is the same with pads, unless you get nighttime pads or heavy flow pads, and then it can be up to 15 to 20 mils. And then we have underwear as well, and I mean underwear designed to catch menstrual flow, called bloody comfy period undies. And they generally hold a varied degree because you can buy light, medium, or heavy. So it's the only real way to have a look at what is a flow and what is captured is to ask the patient how many of whatever product they go through, and then make your best get of what the flow is. Now, to make matters worse, we need to ascertain how much of that is actually blood, because most people aren't aware, but when they talk about blood loss in menstrual cycle, they are referring to just blood. And unfortunately, to make matters, well, I'm going to say impossible, up to 66% of all the fluid captured during a menstrual cycle can be fluids other than blood. So we're talking general fluid, we're talking sweat, we're talking mucus, we're talking urine, everything that is not blood. So recommendations out there is to get the number of pads that you have. Let's say you get 9 pads and they're 10 mil pads, so that's 90 mils. But then you have to times it by 36%, which gives you, around the 34 mil mark, which is normal. So if you are willing to do this process, you're willing to sit with the patient, you're willing to scrutinize and then guess how much of it would be blood and how much of it would be other fluid, then fill your boots. The recommendations are out there. But in reality, it's probably a good idea to trust the patient. And if you're dealing with a patient that has had a period for a while, okay, meaning over 2 to 3 years, generally speaking, is when menstrual cycles will maintain some sort of normality, then if it's abnormal to them, then it's abnormal and needs investigation. Okay, and that's probably the best way you can do it, probably the most hygienic, less scrutinizing way, and probably the most patient-centered way you can do it as well. So just keep that in mind. You can read a huge amount of recommendations out there, but honestly, I have no idea who actually created them because they seem a little bit ridiculous in actual practice. So moving away from abnormal uterine bleed, we'll look at the difference between PMS and PMDD. So PMS encompasses clinically significant somatic and physiological manifestation during the luteal phase of the menstrual cycle, leading to substantial distress and impairment in functional capacity. The symptoms disappear within a few days of onset of menstruation. The pooled prevalence of reproductive age women affected by PMS is around that 90% that we spoke about. Of these, as mentioned, 20% of the women experience enough disruption in their daily activity to have mild or moderate symptoms. Symptoms of PMS include changes in appetite, weight gain, abdominal pain, back pain, lower back pain. We've got headaches, swelling, tenderness of the breasts, nausea, constipation, and then we have anxiety, irritability, anger, fatigue, restlessness, mood swings, and crying as well. Now, when we move into the realms of PMDD, that is a more severe form of the same disorder. So it's the same sort of mix of symptoms, but a more severe case, which has been included in the psychiatric disorder, the 5th edition. So the DSM-5 actually has PMDD in it as a psychiatric disorder. Okay? Many non-pharmacological and pharmacological treatment methods are used to alleviate these symptoms. The non-pharmacological therapies are generally used as a frontline for the mild symptoms, and those severe ones will be generally treated with pharmaceutical therapies, which we'll look into later on. you usually find that a variety of both non-pharmaceutical and pharmaceutical benefits outweigh just using one. So in reality, if someone comes to a primary healthcare clinic and they're complaining of, your abdominal pain, back pain, general tiredness, fatigue, irritability, that sort of stuff, don't dismiss that it could be PMS. Okay, it's very common. Now, I understand that if you automatically jump on it and diagnose every woman with PMS, it may not go well for you because it seems very dismissal. So do the due diligence, do your full subjective investigation, as we'll speak about, and then if PMS is the most likely, then you can go down that line of education and treatment. Okay, so just remember that you won't be diagnosing PMDD, but just realize that if you've got symptoms of PMS, but they're actually severe enough to really impact the person's life, then you're more likely looking at that PMDD, and referral and proper care is highly recommended. Okay, that should be enough precursor. So let's move into our subjective investigation. And we'll start with the event. Why have they come in? So I don't think you're ever going to have a situation where a woman's going to come in and say, I have abnormal uterine bleed caused by leiomyomas. Okay, it's just, people don't do that. So they'll come in with complaints. It's generally discomfort, it's generally abdominal pain, or it's generally heavy flow. That's what people will come in and complain about. But with that, we want a list of all the things that are happening. Okay, because menstrual cycle is so entwined with so many body functions, mostly endocrine based, and the abdominal cavity is already complex enough as far as an investigation goes, you don't want to get in the habit of seeing a young woman in pain and automatically assuming menstrual, uterine problems, all those sort of things. Try not to profile patients and get a list of all their symptoms, and then try to get an understanding of where they're coming from. And if it leads towards menstrual problems, then get a good detailed history about the patient in order to understand what's going on. So you take the symptoms list and then you move on to past history. And we do want to know pretty much everything about their past history, in particular their menstrual history. So we want to know the age they were when they started having menstrual cycle, or their menarche. We want to know their last menstrual period. We want to know the frequency, the regularity of those frequencies, and in their opinion, how long and how much they bleed. Okay, and then any other associated bleeds. So do they have spot bleeding out of cycle? Do they stop bleeding for a couple of days and then start again? All these sorts of unique bleeding patterns can go a long way. So you can get a bunch of variations as we spoke about. Okay, so just keep those in mind. And as mentioned, the volume is very, very difficult to measure, so try not to. Okay, just trust what the patient's saying, and if they're saying heavy, then it's heavy, and that's what it is. From there, we need to move into the sexual and reproduction history, and it's best to know their obstetric histories. How many times they've been pregnant, how many times they've had babies, what mode of delivery they did. If they haven't had children, or they have, we want to know what sort of fertility desires they have, or if they're done. Contraception is a big one. Even though it falls into the realms of medicine, we want to know how much contraception they've taken in the past and what sort of regimes they've gone through as far as the pill, implant-on, because whilst they are effective at what they do, it can, if you've recently got off it, play havoc in your menstrual cycle. Histories of sexually transmitted disease is very important, and also if they've had a pap smear, okay, because certain disorders that are picked up by pap smears can actually lead to abnormal uterine bleeds. Social history, we need to have a general understanding of what sort of social interactions they go through, which includes sexual, obviously, that we just covered, but it also includes an increase in physical activity. So if you have young women that are currently going through a large amount of physical training, there's a connection between the hypothalamus and the pituitary and the ovaries, which we just spoke about, they can actually wreak havoc with someone's menstrual cycle because of the intertwined endocrine. So if a person is going through extreme physical activity, it can actually be the reason that they're now having abnormal uterine bleeds. So that's what we mean by our social and physical training. But on top of that, we also need to know about tobacco, alcohol, drug use, and any occupational risks they may have as regards to exposure to chemicals, things like that. And are they responsible for high stress jobs that may be more attributed to the reason that they're having anxiety as opposed to the PMS? When we're dealing with diet really sits around those high fat diets, high sugar diets can lead to abnormal uterine bleed thanks to that HBO that I was talking about before. Family history is very important, especially when we're dealing with people that have coagulopathies, endocrine disorders, and also history of endometriosis. Current medical history is always a good idea to have because of the HBO and the overall status of the patient that can link to both PMS and abnormal uterine bleeds. And we need to know surgical history, in particular, any uterine-based surgeries. So a massive list. I did warn you that this was a complicated consultation, mostly because of the interaction with so many other potential things. So get a good detailed history and you'll be surprised how far ahead you already are at getting to the right answer to help your patient out. Moving away from our past history, we can move into our subjective investigation. Now, if we're thinking, as clinicians, we're thinking that it could be PMS or PMDD or something along those lines, what we really need to do is we need to bracket the symptoms into three main categories, and they are mood, behavioral, and somatic. So when we're dealing with mood, we're obviously talking about sadness, depression, hopelessness, worthlessness, mood swings, or the inability to display emotional control. So crying a lot, very, very tearful at times that it shouldn't really be sad, all that sort of stuff. Irritability, anger, anxiety, those sort of things. So they all fit under mood. When we start looking at behavior, we generally have our fatigue, the lack of energy, the decrease in interest in normal activities linked to depression, problems concentrating, memory problems, changes in appetite, changes in sleeping, and that feeling of being overwhelmed. Okay, they're your behavioral. And somatic, that's when we look at our physical signs. Do they complain of breast swelling and tenderness? Do they have muscle and joint pain? Do they have bloating or the sensation of bloating or the belief that they've gained weight? And do they have any associated headaches? Okay, so whilst those things aren't uniquely isolated to PMS, when you build a profile of both mood, behavior, and somatic symptoms, it can lead towards PMS. And it's actually the diagnostic criteria is associated with how many of these characteristics you have and when you have them and how frequently you have them that will lead you to a diagnosis of PMDD, which we will not be doing, obviously. Big thing we need to know with PMS is how it interferes with their life. Okay, is it interfering with their life? And if it is, how bad is that interference? Okay, because that again leads us to the diagnosis, puts us in the severe category versus the mild. And we also need to make sure that it's actually associated with menstruation, meaning you have the symptoms during your menstrual cycle, and then the patient gets their menses, a couple of days later, the symptoms stop. Okay, because obviously that list of things I just mentioned is a huge mental health profile, could be a lot of different things. So if it's not directly correlated to menstruation, then it's not PMS. Okay, and generally speaking, you need 2 cycles of the same thing happening before PMS and PMDD will actually get diagnosed. So just keep that in mind that whilst it can be, these things can also be just normal, somewhat normal manifestations of mental health. Allergies, there is no direct correlation with allergies, and in reality, the medications you are going to be giving for this yourself aren't that great, but obviously always ask allergies just to get an idea. Medications, there are a large list of medications that can lead to abnormal uterine bleeds. You've obviously got your anticoagulants, your hormonal agents. Now, it can be either starting a new one or rapidly stopping one that can cause abnormal uterine bleeds. SSRIs can cause it. There also can be a treatment for PMDD, so keep that in mind. And then your natural therapies like soy proteins, ginseed, and ginkgo are also linked to causing abnormal uterine bleeds themselves. So get the profile of what they're on, what natural therapies they take, and then obviously go from there. When we move into objective investigations, we also need to cast a wide net. Okay, because these conditions overlap, we want to make sure we don't miss anything. We need to do vital signs and we need to include BMI. Okay, there is associated risks with heightened BMI and abnormal uterine bleeds to the point that if BMI is over 27, for every point it is over 27, then you have a marked increase of abnormal uterine bleeds. Okay, so whilst it's not the nicest thing to discuss, okay, being overweight has heightened risk factors associated with abnormal uterine bleed and effects on that HPO. Because we're associated with bleeding, we need to make sure that it's not actually affecting the perfusion status of the patient. So we need to look for signs of pallor. Because of the connection with the rest of the endocrine system, we need to look for other endocrine disorders that could have started the abnormal uterine bleed. Because you could have a thyroid disorder that will actually cause abnormal uterine bleed because hypothalamus is focusing on the thyroid or has been dysregulated by the thyroid, which causes a dysregulation in the ovaries. Okay, if you have hyperandrogenisms, they're indicative to people that have histories of PCOS. So the signs of that are male pattern growth of hair. Okay, so generally hair around the person's nipples, on their chin, larger shoulders, and androgen-based growth of a woman. Now, a lot of women will know that they have PCOS, so if you ask them, then that can also be a leading reason to having abnormal uterine bleed. Have a look at their face, look for signs of moon phase, hunchbacks, for Cushing's, for similar effect. Now, obviously, you're not going to diagnose any of these things based on appearance, but it's just an idea to open the possibility of these. As far as the thyroid goes, you palpate the thyroid, see if it's enlarged. Now, obviously, a smaller thyroid can be a problem too, but you check for that goiter itself. Signs of coagulopathy means you look for bruises, look for bleeding gums, that sort of thing. And then you palpate the abdomen as previously taught because they're all really connected. Abdominal problems can be connected, especially if the complaint is associated with pain. As far as pelvic exam, pathology, and imagery, that's all done on referral. Okay, so there is no reason for you to do a pelvic exam on someone with abnormal uterine bleed. So, if you believe it's warranted, because it absolutely can be with some of the causes, it's best done in the right areas with the right equipment and with the right trained people, generally associated with imagery as well. Okay, so just always put the patient first and let the pelvic examination and pathologies get done in the right environments. But realize that that can be absolutely the reason, and the reason alone, that a patient is referred. All right, moving on to our assessment of the actual problem. Now, whilst there is a large list of things that it can be, abnormal uterine bleed has been broken down into a useful acronym called PALM-COHN, okay, provided by the International Federation of Obstetrics and Gynecology. So, pretty good place to come from, realistically. And it underlines the main etiology of abnormal uterine bleeds. When we look at the first four, they describe structural issues that really aren't going to be found without a pelvic exam. Okay, so if you're thinking these, then pelvic exam is needed. The second portion, the COEI, describes non-structural issues. This is where your HBO, your other parts of your body interacting with the uterus is actually coming in for it. And then obviously the N is not otherwise classified. So everything else that can be lumped in there because it's so complex. So polyps is kind of obvious. Adenomyos is a condition where uterine tissue actually grows within the muscles of the endometrium itself. So you have the endometrial muscles that the uterine tissue is now growing into. So it's similar to endometriosis, but specifically grows within the uterine tissue. Leiomyoma is a form of benign cancerous growth. And then obviously you have malignancies and hyperplasia that are causing out of cycle growth of that uterine wall. Because obviously hyperplasia is normal in these situations, but it can also happen out of sequence, which therefore denotes it as abnormal. When you move into the other ones, you obviously have your coagulopathies, ovarian dysfunction, which is where your HBO fits in, endometrial disorders, and iatrogenic itself. Now, iatrogenic is best described as people who are taking medications, that sort of thing. So believe it or not, taking anticoagulants has actually been moved to iatrogenic and not to coagulopathies themselves. When we're dealing with conditions not otherwise classified, we're talking about pelvic inflammatory disease, chronic liver disease, cervicitis, basically an infection of another organ that is causing abnormal uterine bleed. So whilst there is no expectation for you to diagnose it and put it into the categories of these, the main thing we need to do during the assessment is find out how much it's affecting our patient, what sort of problems they have, and then decide whether or not referral is the best point of call for the patient in order to go through further investigations and management for their abnormal uterine bleeds, which we'll discuss in treatment. When we're looking at PMS, if it's mild, generally there is no further action. You just talk to the person and basically get them to monitor if it happens every cycle, that sort of thing. When we move into that moderate and severe realm, and it's basically based on impact of the person's life, then referral is recommended because it comes with special treatment, often done by specialists. So moving into our treatments, we'll start with education. You can educate the patient on mild ovarian problems like HBO, and you can teach them that things like diet and exercise play a massive role in regulating somebody's menstrual cycle. Okay, so that can definitely play a part. You can offer non-pharmaceutical pain relief as far as an education goes. You've got heat pack, some people like cold packs. Okay, people generally have their own regimes. Best thing they can do is just get them to try different things, find out what happens. We obviously can move into analgesia, and Ponstan is a very effective analgesia for menstrual pain. So if you haven't heard of that one, it's highly recommended that you look it up. But from there, the treatment regimes for abnormal uterine bleed really stop from our point of view, and then it gets referred on. And then we move into the realm of oral hormonal therapy. TXA is commonly used for heavy flow, and then most of the disorders, especially the first four, the structural problems, have surgical options. Are the only real things that treat those forms of abnormal uterine bleeds. Okay, so just keep that in mind, that there's going to be a point that your ability to help this patient is going to stop, and referral, but referral with good data collection is always best than just palming the patient off. As far as restrictions go, look at the person's work, look at their PT, think about hygiene reasons, where you are, focus it around the patient and give them restrictions to help support them. Remember, they've actually come to you with this complaint most of the time, so it's really nice of you if you could help them out and consider their comfort without putting them in the corner with kid gloves, but still supporting them through work, PT, keeping clean in certain environments, all that sort of thing. Referral, as mentioned, you're going to refer most abnormal uterine bleeds. you're going to refer most people based on patient comfort as well. Patient's not comfortable having you perform the consultation, then refer them. No questions asked. Okay. Now, obviously the treatment for PMS is slightly different because we can start with lifestyle modification. And lifestyle modification can include regular exercise, avoiding stressful events if that's even possible, but that's what's recommended, maintaining healthy sleeping habits, especially during menstrual cycle or premenstrual cycle, I should say, and increase the intake of complex carbohydrates to support serotonin, believe it or not. Okay, so that's what is recommended from the education side. You can also move into CBT. So cognitive behavior therapy has been proven to be effective, mixed with exercise, more so, for the treatment of PMS. As far as pharmaceuticals go, we have analgesia to manage any associated discomfort and those somatic disorders. And then we also have certain natural therapies that have been proven and certified to work. So calcium, 1,000 milligrams a day, can actually help signs and symptoms of PMS. And the only natural therapy or herbal medicine that's been approved is your Victus angus cactus, which mostly just gets called your Vitrex. And its blend, often available in tablet form or oils, and scientifically proven to help mood swings and irritability during PMS. So, good one to look out for, and a nice, easy, available one as well. From there, we can move into the realms of oral contraceptive pill and SSRIs, obviously on referral for more of those moderate and severe cases. Restrictions, once again, patient focus, work focus. Think about the irritability, think about the work environment. If the catalyst for the irritability and anger is in fact work, you may be able to offer alternative working environments until the PMS can be regulated. Just to consider. And referral, obviously refer based on that scale. If it's moderate or severe, refer. And as always, refer the patient if there is that lack of rapport as well. These are quite sensitive topics. Okay, so that brings us to the end of abnormal uterine bleed and PMS. I hope you got something out of it. From here, obviously there's more that can be looked into and a lot of wives' tales that work, a lot of misconceptions as well. It's actually remarkable the amount of misconceptions that are out there associated with uterine bleeds, menstrual cycle, PMS. Bottom line is, as clinicians, we need to be comfortable and familiar with the realm of complaints that our patients may have, which includes abnormal uterine bleeds and PMS. We chose to be clinicians to treat patients, to advocate for our patients and provide the best care, which obviously includes conditions that are less than comfortable to talk about. But until next time, take care.